to about this in a moment, but I do hear a little bit of background noise, so if you wouldn't mind putting your phones on mute during the webinar, that would be great. So I just want to welcome everyone and thank everyone for joining us today for our 14th Learning Network webinar as part of the AHRQ Fall Prevention Program initiative. Today, we'll cover, briefly the housekeeping information that we typically cover. I want to just spend a moment on the upcoming webinar schedule. And the large portion of our webinar today is going to be hearing from Dr. Quigley. And you're all familiar with Pat. She's been sharing her expertise with us for close to 2 years that we've been working on this project. As you all know, she was formerly the Associate Director of the VISN 8 Patient Safety Center of Inquiry, which has since gone into retirement, but she tells me that she will never give up on fall prevention efforts. So we're very happy to have her with us today. So just a brief word on housekeeping. Again, we encourage you to contribute to the discussion when we get to that point toward the end of the webinar presentation. And you can do that by raising your hand and asking a question or using the chat panel. And as always, we ask you to keep that background noise to a minimum. We are recording this webinar and would like to post this later on the AHRQ website to share this information with others. So please the background noise to a minimum. Just a brief word about our upcoming webinars. We have 6 more webinars after today for the remainder of this AHRQ Fall initiative. The webinar that we have planned in October is, again, we're going to have a special guest presenter, Pat Poza, who's going to be presenting on sustainment of quality improvement initiatives, which is very relevant now as all of the hospitals that are participating in this initiative are really working on sustaining their implementation efforts. The one special note that I want to say about this webinar is going to be conducted on Thursday at 1 p.m. Eastern Time. So you will be joining with the pressure ulcer prevention hospitals for this one single event in October. So I will update the calendar notice, and I invite you to share the invitation with others in your hospital that may be interested in it. In November, we're going to be hearing from another one of our experts, Dr. Kate Walsh, who's going to be talking about teaching critical thinking skills for risk assessment. And then in December, we're going to be hearing from another special guest who's going to be talking about Lean Six Sigma and a deep dive into reducing patient falls, an effort that they have done at their hospital in their system. So with that, I would like to turn the control over to Dr. Pat Quigley, who's going to be talking about measurement with us today. Pat, I'm making you the presenter now.
Thank you so much, Michelle. Dr. Traeger, thank you for your kind introduction and all of your remarks. And, it's just been a pleasure to be part of this process and many of the AHRQ Fall Toolkit and all of the work that you're doing, knowing all that went into place for even developing that toolkit. So it's just an honor and a privilege to be here with you today. It helped to be an expert reviewer, too, for that the Fall Tool. And I know it's been with you all along and other people that are here on the call. So I love being able to talk with you about measurement and helping this come alive because I love one of the quotes that's in the AHRQ Toolkit, Chapter 5. The basic principle of quality measurement is if you can't measure it, you can't improve it. So I help everybody to really have some precision and be able to look at the data and have it be meaningful for you. So again, thank you, Michelle, so much for inviting me to do this talk. So these are the objectives that we have for this hour is to describe core measures of fall and fall injury program components, of which many of them I'm sure that you're actually collecting already. To use it to profile the population and the risk, to apply analysis to program evaluation, discuss elements of high reliability. So we want to get into fidelity and reliability. This is the implementation science process. I think we've shared a little bit about when I've gotten to be on with you before. Examine a framework for dissemination for program evaluation. So when all of we collect so much data, but when you look at the goals of data management, the users of data should be involved in collecting, analyzing, and using the data. It should be simple and understandable and presented in the same way so that it really has a meaning for the staff and that it is concise and precise. And I always, when I talk about precision, I help people really think about, what are you doing to prevent those accidental falls, and what are you doing to prevent the anticipated physiological falls? That's the kind of precision that I'm looking for. And it should be helpful in making decisions and improvements so that you can take action, and if you implement a change, that you really are specific about the outcome that you're trying to achieve, whether it's not reducing those toilet-related falls or falls associated with postural hypotension, having precision. And this should be able to be comparable so that you do have data, tables, and benchmarks and targets, and used to develop evidence-based practice so that you can do some projects and look at the strategies that you're implementing and see if it's indeed evidence-based. And then it would be used for research that's being able to improve practice. So here are some examples of fall program core outcome measures. So these are the outcomes. So there's multiple outcomes that you will see in the literature. Many of you are doing the fall rates, but how many of you are doing the fall rates by type of fall, which is really where we want to go? And that you have precision. Or how many of you are looking at repeat falls? So you could have a repeat fall rate, or you look at the percentage of repeat fallers, and the repeat fall rate, your fall is the outcome, but the percentage of repeat fallers is at the person level. So the person is a target of interest. What percentage of fallers? Those two ones with fallers, when you're looking at the person level, you're not just looking at the outcome. You could have one person who falls multiple times, so the percent of people that were fallers, but that would be a different rate than the percent of people that are repeat fallers. So you look at how you actually calculate that. And then the percentage of falls with injury, which people are doing in severity injury levels. But what is fear of falling? How many of you might be doing fear of falling? And that's that fall self-efficacy, a different kind of an outcome measure. Or not powered on a study or a project to look at falls, maybe you're looking at improving gait and balance, which is work that I've done in the past in one of my clinical trials as a proxy for falls, because if you improve gait and balance, you actually are ultimately reducing a fall risk. So those are outcome measures, but what are the structure measures that you're looking at? And structures are formative measures. Outcomes are summative measures. So formative measures is, are you looking at staffing, or are you making a change in staffing? Skill mix. Are you using a valid and reliable screening tool as the basis of your structure for care planning? Do you individualize care plans so that it's not just universal precautions? Is that part of your structure where you can actually measure the number of risks that a person has and whether or not they're modified or eliminated? Your interdisciplinary team, how many of you are keeping track of your interdisciplinary team members who coming to team meetings or participating in Postfall Huddles or involved in care planning? Your patient population profile, are you actually controlling for that? Are you looking at what percent of your patients in terms of structure are over the age of 85? What percent of your patients are 75 to 84? Profiling your patient population, that's your structure. Your equipment that you have available, all of these are examples, and I know many of you could come up with other examples of structure that's in place. And process measures. The process measures as part of formative measures are really important whenever you're evaluating a fall prevention or injury prevention program, because this is what is being done. This is what in place, and then what are you doing to implement a change? So this is the timeliness of your fall risk assessment or the completeness of it. So not just screening, you'll not see anything here for screening, but actually doing a multifactorial assessment and completeness of it. Actually measuring that, or the timeliness, how long does it take us to implement a care plan? Are we actually following that, or the timeliness of the care plan being developed? We're going into using floor mats. How long does it take you to get a floor mat at the bedside for someone who needs to have it? If you have a patient who needs to be on a scheduling program, if we found out that there was a problem with blood retraining that needed to be done, that we actually implemented a toileting program and we actually are measuring the timeliness of it. If it's going to be done every 2 hours, is it really being done? So what are you looking at? program, this is a Donabedian model. You want to look at structure, process, and outcomes. And remember, as we've said before, you have to measure structures and processes twice as much as you do outcomes to be able to measure the effectiveness of any program. As you'll see on this slide, we put it all together to really evaluate a program and help this all come alive for effectiveness. You have to look at all the components. You have to look at program effectiveness, which usually the program elements, the team that's in place. Then you have to look at the implementation effectiveness. How well are you implementing it in terms of reliability? Is it being implemented as it was designed to be done, which is fidelity? And then look at the outcomes and make sure that they're all aligned. To look at this model, the plus sign means that it's effective, but the minus would mean that it would be something that's ineffective. So you have a good program, but you don't do a good job in implementation. The outcome's going to be inconsistent. It's not going to be sustainable, and you're going to have poor outcomes. So I'm sure that this October 20th session is going to be very interesting in relationship to sustainability. You have a program that's not well designed, but you have everything in place to implement it, then you're going to, again, have poor outcomes. So all of it really is related when you're looking at structure, process, and outcome. So be clear about the data that we're collecting. In the work that I've done, I've always used mixed methods, if you will, where you collect quantitative and qualitative data. Well, the quantitative data are the ones that you can actually measure. The quantitative data, you have attributes that are categorical measures. That would be nominal data or ordinal data, or you could have variables that are continuous measures that you would have interval and ratio level data that you would be collecting. The qualitative data, in contrast, is where you're doing like grounded theory research, where you're collecting opinions or perceptions, or you're trying to identify themes. People are coming together. Maybe you're doing focus groups as a way of being able to collect qualitative data. The qualitative data often can give us meaning to the things that we're trying to evaluate or see if they're actually going to work, or the perceptions of people that are going forward. So let's very briefly at the types of data. Nominal data, the nominal data are the ones that actually are coded and can be sorted. So this would be ones that you assign a number to and give it to an attribute. A category that's unordered, a category that could be exclusive or exhaustive. And nominal is the lowest level of measurement, but it's only binomial, by choices, where you actually assign a number to something like 1 for yes and 0 for no. That would be nominal. So nominal data, if you look at some examples here, like for gender, you could have gender 0, or male that's a 1. You could have codes for ethnicity type, marital status. So this is where you take an attribute and you assign it a number so that you can run some statistics with it. It would be nominal level data, the lowest level of measurement. This next level of measurement would be ordinal data, and this is data that's assigned to categorical variables and attributes that you can now start rank ordering. And there are rules for how you can rank order them, and there are categories that, again, that are exclusive and exhaustive. And the quantity of the attribute can be identified, but the intervals between are unequal. So this is the example of the Moore scale. If you look at the Moore scale, you do have a continuous scale from 0 to 125, and you've got the variables in there. But what many people do is they reduce these the continuous scale back to a categorical variable by reducing the Moore scale to 1, 2, or 3 for low, moderate, or high level of fall risk. Take a continuous data and you reduce it to an ordinal level, and that limits the amount of the types of statistics that you can do, the way you can use it in research. Other examples of ordinal data, the level of pain that some might be having, sibling order, degree of coping, satisfaction scales, acuity levels. You can severity of injury scales that many of us are using. It would be any type of a Likert type scale as ordinal data. So here's another example. Is a program actually meeting the personal objectives? And you could go ahead and have strongly agree to strongly disagree, and each one of these would have a number that would be assigned to it. I used a self-assessment tool of organizational infrastructure and capacity to reduce related injuries. And all those variables have an ordinal scale of being able to say, from a scale from 0 to 3, something that's not being done at all to being fully implemented. So that's an example of an ordinal scale. Now, the next type of data where you start having where you can sing into some inferential statistics, the first two ones being descriptive statistics, is interval level data. And this where you have distances in the intervals on the scale that are equal. The data categories are exclusive and exhaustive, but you have a continuum of variables, and it's continuous, but you only have a 0 point. So in interval data, here are some examples of those. The number of days between preventable falls, many of us are doing that. The number of days between serious injury, we oftentimes will see these on charts that are available on units. Maybe it's a blood pressure on admission to a nursing unit then 2 hours later or 4 hours later when you're looking at postural hypotension. The type of data, the last type of data, and your highest level would be your ratio data. This is one where you actually have a 0 point on interval scale. It can't be negative, but it is continuous. This is the highest form of measurement where you can do very rigorous statistical analysis, your ANOVAs, your regression analysis, those kinds of things that can be done. You have this kind of level of data. Most research that you see being done on fall for intervention in hospitals, we're looking at all kinds of variables, but it's really mostly descriptive kind of studies, so it's limited types of research and analysis that can be actually implemented. An example of ratio data, you have weight and length and volume of blood pressure. And you see the example that's right there. But that would be the very highest level as we had just mentioned. So any of the data that you're collecting, we always want to also ensure validity and reliability. And these are characteristics that we need to have in place when we're looking at measurement. Validity is the measure to which the extent an instrument, for example, is up when you have two people implementing the instrument or you have repeat measurement of the instrument. Look at the Moore scale. The Moore scale was designed exclusively to be done, is it measuring what it was set out to measure. The Moore scale was designed to actually identify the likelihood of the anticipated physiological fall. That's what really sets the Moore scale apart, because in terms of validity, it is measuring what it was designed to measure. So many of the other scales that you see out there in the field were designed to measure falls as an aggregate, not a precise type of fall that you see here like the Moore scale. And reliability is where I was mentioning that if you get consistency of measurement, two people measuring something the same way or two people with some measure something twice, they get the same response. So there's an internal consistency of what is actually being measured. So, the example of in history to falls, yes, for someone who gets admitted because of a fall or has a fall within the last 3 months. If people are actually doing this, are they using the scale as it was designed to be done? Is inter-rater reliability? You can have intra-related reliability or inter-related reliability. So the characteristics of many of the instruments and the surveys and the tools, that's what you're always looking for when you select an instrument to go forward and measure something, is the validity and the reliability. When you look at data and tests, there's only certain tests that can be performed on certain types of data, and that's when you get into the statistics. And understanding the type of data will determine the test that can be appropriate to it. And then understanding that data type will guide decisions on the strongest, the most robust data that you want to be able to have included in, whether it's quality improvement or research or program evaluation, so that you can use the most sophisticated analysis and get the bang for the buck, if you will, in analyzing the data that you are collecting, because it takes a lot of time to collect data. And more sophisticated analysis generally provides richer data analysis, so an interpretation of findings, which is why so much of the work that I have done is to be able, and where I worked in my patient safety center, we use mixed methods, quantitative and qualitative data. So evaluating programs, I think I'm the only one that's ever published a prevalence study where, because we're using the Moore scale across all of our VA medical centers, but not only 99%, probably 99.9% of our days were, but in my VAs in Florida and Puerto Rico, I actually conducted a prevalence study. I could profile how at risk the inpatient population was based on the Moore scale for anticipated physiological falls. And even a snapshot in time, like you do prevalence studies for pressure ulcer risk. You can do prevalence studies to profile how at risk your patient population is. I published that work in around 2008, but I was actually able to show that as the patient population looked at the increasing age groups, the level of risk on the Moore's fall scale scale for the anticipated physiological fall increased. So think about it, being able to say that 80% of your patients are at risk for an anticipated physiological fall, but maybe only 20% of your falls for that type of fall, that's a very powerful message. So those are things that you can do when you start getting into evaluation methods to look at your patient population. Formative and summative evaluation helps you to get into the types of falls. You want to be able to get past that overall aggregated fall rate and get to the types of falls, because that's where the rubber meets the road. Are 8% of your falls anticipated physiological falls, or are 8% of your falls accidental falls? That's a very different picture based on what type of falls are happening. And then into the severity of injury, how are you really measuring this? What is your evaluation of injury? You can't measure injury at the time of rescue and think you've captured all the injuries that someone has had when they fell. You have to be able to look at the duration of the extent of injury evaluation and the extent of injury, because oftentimes what happens with injury evaluation is you have reported the most serious injury or severity of injury level as high, but it doesn't say if it's a hip fracture or a head injury. But people fall and hit multiple body parts, and not every body part has that serious level of injury. So it's the highest one that gets reported. So how do you make that evaluation? And then you look at repeat falls. Are you looking at the repeat fall rate, the repeat number of falls? Are you at the repeat faller level, the person level? How are you doing that? Or survival analysis, which is really moving into the number of days between the serious injuries or the number of days between preventable falls. And then I'll give you some examples in terms of evaluation, in terms of run charts, which are very, very powerful as well. So lots of ways to build your evaluation model. Revisit falls as an outcome. Remember, if you're focusing on falls, measure preventable falls. That's really what I like to help people think about. Preventable falls, if you're getting to that, then that implies that you're looking at all falls as if they're the same. And we need to have more precision. You want to have your measurement, your evaluation to have precision, so that there's as much meaning as it possibly can have, so that you know the interventions that you're implementing, are they making a difference or not? Or are they being successful in their implementation process? Are you measuring effectiveness of interventions or are you also measuring effectiveness of interventions to mitigate or eliminate risk? So it's in that David Oliver article that you may remember. I'll mention it very briefly next. But there are two recommendations there that really help us to appreciate that we have to evaluate some of the risk factors and then intervene. The number and type of modifiable risk factors might be a better measure of your success of your actual fall prevention program. So in that David Oliver article, November 2010, Clinics in Geriatric Medicine, knew that 30 to 51% of the patients who fell in the literature had an injury. We don't know the extent of how they were evaluated in terms of their injury, but they had some injury. 80 to 90% of the falls are unwitnessed, and is that maybe something that you're looking at? Or injury, where are they falling from? 50 to 70% of the falls are happening from bed. Are you doing something different about it? And then we also were reminded of all the fall risk factors that one has. In the article, again, David Oliver and at Geriatric Medicine 2010, the most effective intervention should target both the point of care and strategic levels. For those recommendations, there are just 4 of them that are really the framework for best practice approach in hospitals that we implement across the Department of Veterans Affairs for years now. This was published in 2010. But you all have a responsibility for implementing a safer environment. And when you implement a safer environment for the entire patient population, you're reducing accidental falls. Next 2 recommendations, which I was mentioning on this prior slide right here, recommendations number 2 and number 3, where we have a responsibility to identify modifiable fall risk factors when we do a complete assessment. You measure that. You could have patients who come in and they've got 15 fall risk factors. 10 of them are modifiable, 5 are not. The one modifiable, what are we going to do? We're going to help treat them, which is the implementation of interventions. We have to treat those risk factors. The 5 risk factors that are not modifiable, what are we going to do? We're going to help them compensate for them. We're going to teach them about those risk factors and help them compensate. So you'll recall that the 4th recommendation is if someone does fall in our care, we don't want them to get injured. That's the injury reduction strategy. But colleagues, you can be very clear that if this was your theoretical framework or your strategic model, your strategic planning model, in the Falls Committee, if you were going after implementing a safer environment, then this would be clearly aligned to reducing accidental falls. If you were going after implementing, identifying specific modifiable fall risk factors and implement interventions to reduce those risk factors, you'd be going after the anticipated physiological falls. That then brings us back to the Moore scale. This is already aligned. Your structure is you're using your Moore scale to assess risk screen for risk factors and do an assessment, an individualized plan of care, to reduce risk factors, which is ultimately reducing your anticipated physiological falls. You can just see how you've just built that model for a very, very dynamic evaluation study you could launch. And then the interventions to be able to protect from injury are separate and distinct from the fall prevention strategies. So you're calculating rates. You have probably a very consistent formula now for calculating rates. I know when the hospital engagement networks got started a couple of years ago, we're getting ready to launch 3.0 now. People were still collecting fall numbers, and they still didn't have consistent rates. The NDNQI, the National Database for Quality Indicators, had operational definitions for all of its rates. Some people, have their rates. And then you have to look at, is your formula actually standardized? And, what's your formula for fall-related injury rates? And there are different rating scales for injury severity. So we just don't want people reporting falls, the number of falls, because you can't do any kind of comparison with that. But a typical fall rate formula, the number of patient falls divided by the bed days of care times 1,000. But if you were an NDNQI, NDNQI had 5 options for that denominator to select the number of days of care. So, even though you might see the fall rates that were reported by NDNQI research, it doesn't mean that they were clear about which numerators were used in which hospitals, because hospitals, when they sign on contracts, would determine what formula they were using to determine that number of bed days of care. But then how many of you, again, are measuring your fall rates by type of fall? If you're able to showcase at your unit level, your organizational level, to the Board of Trustees that, only 10% of our falls are anticipated physiological falls, 40% of our falls are accidental falls, and the other 50% are those falls we can't prevent. I mean, what a picture does that paint when you're telling a story? So I love for data to tell a story. The fall injury rate, the percentage of injuries, this is where you have the number of injurious falls divided by the number of falls. This would be a percentage times 1,000. So this would be all injuries, and that's a very different measure than reporting the number of patient falls with injury divided by bed days of care, which is usually where you get your fall injury rate. So you have to decide on which numbers or which formulas or which combination of formulas best paint a picture of what is happening within our care. So be analyzing your fall injuries by severity as well, the severity levels. Again, remembering that you could have one patient who has on a fall sprained wrist, from an elbow, and fractured a hip because they reflexive posturing and reached out before they actually to break that fall. So you get 2 serious injuries and 1 moderate injury, all with 1 fall, 1 person. How do we profile that? And the multiple, as I was just mentioning, the multiple injuries. So that's a very different kind of measurement. So a percentage example. An example of injury rates. Your facility had 80 falls in the last month. Of the 80 falls, 5 of those falls were a minor injury and 3 resulted in major injuries, such as a hip fracture, and the remainder had none. So there's your minor injury rate, and there's your major injury rate. So you had the minor injuries. Remember, in older people, minor injuries can be grave, so you still have to carry out that extent of what's your duration for measuring severity of injury. Ask yourself if what you're doing is truly enough. Do you really know what's going on? How do you truly know that your program is indeed working? How do you know people are doing what they are expected to do, and that they're doing it the same way across all people, so that you can have confidence in your outcomes? We want to know, how do you know if your program is working? How do you know staff are implementing a practice the same way? Like the Moore scale. I mean, I can tell you for any scale or what it takes to make sure people are doing as it was intended to be done. The transfer measure or the mobility measure, there's a component for, if they're not walking, is that you measure how they use it, do the activity with a wheelchair. And then how do you compare your rates with units, recognizing that units can have a very different context, a very different population. So on fall rates, getting to those repeat fallers, we want to really tackle this. Who's having those repeat falls? And your goal is going to be to reduce the delay repeat falls, a delay by a day or so. This gets into the time of the occurrence. That's oftentimes a method that I have suggested for rehab units that are working with really tough patients that they're dealing with, like traumatic brain injury patients who are so impulsive, or right brain CVAs. If you delay a repeat fall from occurring by a couple of days, you've done a really good job to have an opportunity to celebrate success. Or start getting into diagnostic cohorts, looking at the fall rate. So, I've seen this done with orthopedic patient populations, orthopedic hip fractures. In rehab, again, the stroke population, but still stroke is too aggregated. You have to look at left brain versus right brain CVs are very, very different. Into the known patients with fall-related injuries, looking at the people who come in and they're already injured, or they got in admitted because of a fall, are they fallen? So going into different populations is really important. So this is an example of really helping the data come alive, because I can design and have designed a program evaluation around post-fall huddles, and this is getting to your repeat fallers. See, this is an example of a special emphasis population, and you can pick your own. You could do this with new moms. You could do this in a hospice population. You could select your own. But you want to do safety huddles, the post-fall huddles, and designed to be done within 15 minutes of the full event with a patient. And the question was always to get at, the question of the post-fall huddle was always to get at the root cause of why someone fell. So you're always asking 3 times, with the patient, what was different this time you were doing the activity compared to all the other times you did it, and the other times you didn't fall, but this time you fell. Trying to get to the when, the how, and the why of how they fell. So that you do what? Come up with a protective action strategy to prevent it from occurring again. So the post-fall huddle, right here you've got a time factor. You've got a timeliness to be able to measure. You can measure who came to the huddle, which would be, was it more than nursing, which gets the structure? Did a team member come, like a physical therapist is into the unit on a given day? You get to the structure and the process of it, because if it's not done the way it was designed, then you can't expect to be able to achieve the outcome. And outcome is making sure someone doesn't happen because of the same reason. So the outcomes of the post-fall huddle is, the reason why someone fell, the proximal cause, the immediate cause, the root cause of why someone fell. Then you get into the type of fall that just happened. And I had a conference call today with one of my VA organizations that I've worked with before, and helping them to work through this post-fall huddle again on long-term care to help find out, make sure they know, why are people falling in our care? The actions that could be put in place to prevent reoccurrence, and a plan and the change in the plan of care. So right here you're looking at the root cause. You're getting to that's essentially the reason why someone fell. The type of fall, when you getting to the being able to analyze types of falls, is all based on the reliability of your post-fall huddle. The actions to prevent it from occurring again is going to be your follow-up plan of care, and was it changed? So those things are process measures getting into identifying what needs to be done and how long did it take us to change the plan of care, get it implemented. Making sure the patient is involved, that would be part of the structured process. And then prevent that repeat fall from occurring based on the same root cause. You get someone who's a repeat faller, but in terms of the post-fall huddle effectiveness, the true measure of effectiveness is that a patient did not fall because of the same root cause. So here's the amount of precision that's really needed to do the post-fall huddle. So the formative measures, when you're to differentiate between formative and summative, is to sure who attends. On the shift, you're going to have nursing, but there should be more than nursing that comes. You've got a physical therapist on a unit or a hospitalist, and they're there when someone comes. They should come to the huddle. A change in the plan of care. If there's no change in the plan of care, we're not done. And if in my storyboard on a unit, I want to have these actually annotated on a run chart on a unit. It's not. I don't want a line of fall rates on a unit. I want a storyboard on a unit that says the patient fell, what was the root cause, what do we do about it. On the next mark would be the next date that a patient fell, the root cause, and what do we do about it, so that the nursing staff can see that know why people are following our unit and that we're following up to make sure that things get done to prevent it from occurring again. That's the heartbeat of my storyboard. So there's a structure. And then process measures would be the timeliness of things, making sure that post-fall huddle was done within 15 minutes, timeliness of getting that change in the plan of care done, but then following up to make sure that it actually got implemented, which is making the whole post-fall huddle process come alive. But there you have 3 measures of process, and you've got measures of structure. And I mentioned you have the summative outcomes, which is preventing that repeat fall based on the same root cause, the same type of fall. And ultimately, you're reducing the costs that are associated with falls and certainly fall-related injuries when you start reducing the burden of the repeat falls. So we were just delighted to have someone put us on hold here.
Good Shepherd Medical Center is looking for men and women with a passion for health care to join our team.
Was it possible for you to mute
Texas.
the line?
It takes about 3,000 clinical and non-clinical employees across the region to make good shepherds.
Thanks so much. Yeah, thanks for doing that. In the collection of fall-related data, it does help us to answer these questions. What data are you collecting?
Had to have somebody on.
Thank you for your help. And variables evidence-based, are they reliability and validity data, and are you collecting data from EMRs or narrative notes or observations? Observations have a little bit more reliability as long as everyone's really trained. If you can observe, make sure someone are training, but we know what the limitations are of going back and collecting data in EMRs. They're so checkbox oriented. And of notes, not everybody documents the same way, but you have to have people who are trained to be able to read notes. But whenever you're deciding on your data collection, you have to plan all this out, which is really important. And when I mentioned about the mixed methods, when we launched the post-fall huddles, we actually collected data on the post-fall huddles about the effectiveness of being able to reduce repeat falls based on root cause. But remember, we also did qualitative research. We actually did focus with the nursing staff to ask if this was something that was really value-added or more burden. And then we learned the true meaning for them, the nursing staff, and this was nights on med-surg, that it's so powerful about the post-fall huddles is that they didn't have to deal with the fall alone. That's the value of really being able to talk with people, get their perceptions, and rather not just collecting numbers. But when collecting numbers, you're going to collect and drill down on data. You're going to define the data elements. You have to have operational definitions so everybody's very clear on what does this mean. It's just like being clear to link everybody when they're using the Moore scale to only one type of fall, the anticipated physiological falls. You cannot look at the effectiveness of the Moore scale in relationship to all falls. That's imprecise. You have to define your data elements. You have to determine the frequency of data collection. You have to, and be realistic about it. And develop data collection tools and pilot test them and make sure that they're going to work and that they're clear for anyone who's going to use them. That's such important parts of planning. And then have a data code book so that anybody who comes and starts collecting data or is going to be involved in your quality improvement project or program evaluation or maybe research understands what the data means and determine where to find it, so that people can easily go back and find that data. And then establish your reliability. So those are all the planning parts, even before you get started in looking at the data that you want to collect. So, for example, in improving your falls programs, your interdisciplinary care planning, you need to be able to define out, what are you going to include in terms of your interdisciplinary team, core members versus others, what's their involvement in assessment of patients and their implement care plan. Or do the post-fall reviews, and I just gave you a framework for being able to do that. Or maybe integrate technology at the point of care beyond the med alarms, which we all know doesn't work with fall prevention. So storyboards, because the storyboards are what really paints the picture, and people, that's their go-to image for units to be able to know that it's for our patient safety effort. So this example of a fall rate by patient days, 1,000 patient days, And you have your upper control limits and your lower control limits. Those are the dotted lines around your average. And you have variations that occur on a monthly basis. Those are the data points that you will see. This is made up data over a couple of years. But ultimately what you're trying to do is to run this down and reducing the variation that's allowed around the mean, but getting below the mean, as you can see, the national mean. But remember, this is all fall rates. It only begins to paint the picture. It doesn't tell much when you look at all falls as if they're the same. But when you get to fall rates by type of fall, now this is where you have a story. So you've still got that overall fall rate, but you can clearly see that the majority of falls that are happening when you look at types of falls are anticipated physiological falls. So if I know that when I come to visit an organization or visit someone else's unit, if it was in my hospital, exactly what's the problem. If most of our falls are anticipated physiological falls, we know we don't have assessment, we're not doing assessment, we don't have an interdisciplinary team. Because that's all the evidence to be able to reduce anticipated physiological falls or multifactorial. You have an interdisciplinary assessment and you have to have the interdisciplinary fall prevention plan of care. Most of what you find in electronic medical records in the hospitals is a nurse managed program. So we have a lot of opportunity. This example of number of days between serious injuries, this gets into your survival analysis. So every data point is a number of days we went before we had a serious injury. So on the y-axis, you have days between serious injury. On the x-axis, you have time. This paints a very different message, too, which is really, it shows how protective our environments are. And it'll be an example of an annotated run chart where you're capturing innovation. And I know when we were doing our team work with AHRQ, we actually captured all of this. I just don't have my drop-down arrows to the point in time. But we kept track of all the innovations that we were implementing over time and how we're able to successfully continue to sustain them so that they became bundles. This is a really fun story board to have on your units, is to be able to capture what is it that we launched. When did we come up with an idea? Did we get buy-in? How long did it take us to prepare to launch this? What was our pilot testing time? And when did we perfect it that we could actually go to the full-scale implementation? A really fun run chart to do with the nursing staff. This is a different run chart where you're actually just looking at an outcome, if we're reducing the amount of restraints, there are restraints over a period of time. And some of you will remember the days in long-term care or even in hospitals when you use restraints to prevent falls. So your restraints went up and your fall rates went down. In this case, the restraints were going down, absolutely, because we went restraint-free. Or kind of a control chart for a pilot unit where you're looking at the fall rate before you launch something, then you launch the whole program on the pilot unit, and you looked at decreases in the average monthly fall rate when you launched an intervention after implementation. So this is a phased-in control chart where you had the phase of implementation and do a post-fall assessment. The G chart, we look at the number of days between serious injuries due to falls. Another example that you had seen before. We just go ahead and change the X and Y axis on this one. That you want to paint a picture because it's not just the numbers. You want to know, is your program indeed improving? Are your patients safe? How many of you can really say with confidence that your patients are safer? And with falls, this is so important because with all the work in the hospital engagement network, falls is the only one adverse event that is not going down. And how many of you can say that the patients who are cognitively alert are even more confident because they came into your care, that they're going to be better off after they leave you? So there's lots of ways to paint the picture, and that's when we start getting into implementation science. I love this world, and I'm so glad it has so much emphasis because at heart, I'm a clinical nurse specialist. And as a clinical nurse specialist, you're implementing programs helping staff to be clinically competent and feel good about the work that they're doing. So you work yourself out of a job because you've built clinical competencies and structures and processes so that you know things will be done. So implementation science is a study of methods to promote the integration of research findings and evidence into health policy and practice. And it helps to understand behavior of healthcare professionals and stakeholders as key variables in the sustainable uptake, adoption, and implementation of evidence. So this is closing the gap in practice. So the questions that actually get asked in implementation science, you want to be able to create generalizable knowledge so that you can say, why are things working? And the questions that you ask why do things lose effectiveness over time? How do things fade away? They lose importance, they lose relevance for something that we all thought was really important to be done. Or do tested programs sometimes exhibit unintended effects when they're transferred to a new setting, when people don't even control for context? How you roll something out on a day shift is very different than the night shift. How you roll something out with a group of novice nurses is very different than a group of expert nurses. Another question that you can ask is, how can multiple interventions be effectively packaged to capture cost efficiencies and the splintering in healthcare systems? This has a lot of promise in today's world when you look at all the efforts and the PAC programs to look at bundled care. So implementation really does matter. It helps us to identify and adopt what works and what's not working to understand so that we can reduce the barriers to implementation and achieve successful outcomes. And we have evidence-based programs and practices still that need to be delivered, but we have to assure fidelity and reliability across all settings that we're working in. And one of the strongest messages coming in terms of research is fidelity, the quality to which treatment is delivered. And this is critical to implementation for successful outcomes. Not for the faint of heart to change practice. It can take 2 to 4 years when you look at trying to do all that needs to be done in terms of planning, installation, implementation. So the phases that you have on this slide, even being able to explore, is this possible for us to do? Then to get what we need to have in place, and then to do the initial implementation and testing, the pilot testing, be any kind of pushback and resistance. And this is, remember the word of innovation diffusion, and you're getting ready to deal with a lag. And then get ready to implement full-scale implementation, and then innovation and sustainment. So I tell you, when we were launching the Barcode Medication Administration years and years ago, we had national implementation, all the lessons that were learned over time to be able to really make it fully work and fully operational. So key implementation supports is you've got to have implementation teams. Many people have moved into the unit-based champions for falls, community practice where you're building expertise, and have that data-driven feedback. Remember, it's not just the number of falls. It's how is it working? How is your program going? How is the structure working for you? What are the processes? Are people coming? Is it timely? Are you getting the feedback? Developing the competencies? And then the Fidelity Assessments and formative program evaluation. And then you get your practice to policy feedback mechanisms, because you just don't want to put something out on paper and think it's going to be done. And that involves key leadership. And leadership is so important. All the last 4 false toolkits that have come out, getting leadership on board is one of the first chapters of all this work. So getting leadership on board to help with fall prevention is just still a major priority in today's world. So when you look at high reliability organizations, the high reliability organizations are those that are achieving a high level of success or reliability despite dangerous or hazardous conditions. And I'm very interested in this because we all do want to minimize errors and achieve exceptional performance in our patient safety and quality. And there are several studies that have indicated core processes in healthcare that are defective 50% of the time, so we have to reduce this. And you're going to be looking at Lean Six Sigma as part of this as well. And Kate's going to be helping you with dealing with clinical competencies. But patients receive about 50% of the time the care that they should expect with the care delivery system. We need to be able to do better than this is what we want to be able to do. So this is when you get into fidelity assessment. Is the extent to which a delivery of an intervention adheres to it. It's done as it was intended to be done. And you establish fidelity measures. This is critical to achieving outcomes. This is where oftentimes observation can tell so much. How well is your handoff being done? Is it being done as it was designed, as it was taught? But I think the last time we were together, we talked about purposeful rounding, which I'm not a fan of. But for those who are doing that, I haven't found anybody who is implementing purposeful rounding the way it was designed to be done. And they're morphed it all over the place. So make sure that things are being done as it was intended to be done. Toileting, scheduled toileting is important. So Fidelity is concerned with the structure. Do we have everything in place and the processes to make sure it's done? The whole issue of adherence. Adherence is it being delivered as originally intended and designed? Like the flare-ups are only down when the patient's resting in bed. Hip protection are only for those patients at risk for osteoporosis or already have a hip fracture. I mean, that's that whole issue. Is it being done as it was intended to be done? Exposure gets into the number of sessions that was supposed to be done. Are we really making sure that someone who's supposed to start doing early mobilization is actually having these sessions implemented? Quality gets into competence, skills, and enthusiasm when you're looking at the quality of care delivery. How passionate are people about really helping to really protect people from an injury if they were to fall, protect that 85-year-old. Protect responsiveness is getting people engaged. This is engagement and retention, that you have people that are willing to make this really and stay important. Then program differentiation, it helps us to identify the unique features between programs. So that's really important components of any kind of fidelity assessment, really, that you have to control for context and compliance and competency. So there are two fidelity assessment, and so these are the questions that get answered. If you change the structure, if you actually change structure, what effect will it have on process and outcomes? You have to think through all of that. If you implemented change in practice, what approach are you going to use to implement it, and what did you use? This gets into being able to detail what is it that you tried to do, how did you implement it, what was your process? I come back to purposeful learning. As people have tried to make sure that this gets done, as I mentioned, they've morphed it so much, but people don't keep track of all the changes that they made when they were trying to implement this one approach to patient satisfaction, improving patient satisfaction. How many of you can say how confident you are that something that you're testing is actually being done? You're checking for postural hypotension, that everybody's doing it the same way. I just had this conversation earlier today with a group of people. And how do you measure reliability, the accuracy and the timeliness of the implementation, that everybody's doing it the same way? And how do you know that a change that you're making is indeed effective? Did you really link it to the correct outcome? And it's really important when you plan this out. And reliability science is different, because reliability is the capability of a process or procedure to perform its intended function over time or between people. And we talked about what this meant earlier. How to quantify reliability, and then some people do the defect measure, I do the Lean Six Sigma, but we're not an operation line, we're not an assembly line. We have a lot of loading components. We're very complex, so this sometimes gets hard to do, but there are ways to make sure that people are doing the same thing the same way, like the orthostasis. But it helps us to standardize our approach and build some decision aids and reminders. Just like our electronic medical record in our Postfall note, we actually built in how to check for postural hypotension, the time frames for measurement. We had in there that people could click on and get information about it if they had any questions. The same thing with the Moore scale. You take advantage of pre-existing habits and patterns, and you help them, be able to make sure the desired action becomes the default rather than the exception. And it's just to reduce redundancy, and that's when you start bundling related tasks, and it all depends on teamwork. So change practice is not for the faint of heart, which brings me back to the PDSA model. I love this model, and I've got built into here about Donabedian's model, where you have to control for structure and process. If you don't, you're not going to be able to affect outcomes. You can do all your PDSA cycles. If you don't make sure you have a core team, keep them going. If you don't make sure processes are in place, then it doesn't matter all these iterative cycles, it's going to be very tough to be able to implement. You've got to have structure and process. So we all should be planning, and that's the most important phase of anything that we're going to do. In this planning, you decide on what is it that you're going to do, and then you operationalize it, and then you have data collection tools. So you plan it, and then you're going to do. With every time you implement something, every small test of change, people have to keep notes. What worked, what didn't work. You've got to take notes and then study it. And then you're going to make a decision for what to do next. And that's the study part. After you've looked at all of this, is to look, what do we need to do? How are we going to reduce barriers and increase facilitators? And that's when you act. So each one of these steps are really important. So you've got to collect data on it, because every PDSA cycle is an iterative process to get things to work. To be successful, whatever you're trying to do, you want it to be successful, and you want it to improve patient outcomes. So remember, if you go back to the model, you've got to look at the program. You have to define the program. Then you have to get ready for implementation. And then you have to be clear about the outcome that you're going to measure, and be precise, and don't over-collect data. PDSA model, remember, this is a theoretical approach to change. This is plan change theory. So whenever you're implementing change, you can come back to a theoretical approach and keep track of those PDSA cycles, because essentially if you can do that, then you're going to build the toolkit for what worked. It doesn't mean that because it worked on a rehab unit, it's going to work on a hospice unit, or it's going to work in psychiatry. We maybe have a generalization to another rehab unit. But you give it a try. And now it's making sure that we're measuring what it is that we're intending to measure so that we can know whether or not we're making an improvement. So, colleagues, the principles and guidelines for testing is when a test of change, be specific. What is the question that you're trying to answer? Test of change, it requires a theory and prediction. Can you make a difference in reducing accidental falls? Make a difference in reducing anticipated physiological falls, let's say with toileting. I can have a very specific intervention for that of practice change. Test things on a small scale and collect data, and then get ready to build upon that so that you can do the iterative cycles and then plan for changes as you go forward. And every one of these is on a hunch, something we want to do to be able to make improvements before we do wide-scale changes. If you don't, it will fade away, and that becomes the very first premise of why we do an implementation science. We want to know, why do things fade away? Why can we not get things to change and become enculturated and know with confidence that people are going to do this because it's so important and we know it makes a difference in patient outcomes? Implementation science and strategies, they do help to try to analyze PDSA cycles, empirically designed to give us insights and tools for high implementation improvements with diverse and complex real-world settings. And these champions are a winner. And then you've got to build your guidelines and your models, if you don't have them already, your manuals, and make that you're holding people to the fire, that you're having the meeting. Just like I said in terms of Postfall Huddles, we made huge successes with the Postfall Huddles, but this took us time. So over the formative measures, the summative measures, we were able to show a reduction in repeat falls and people reducing the amount of people that were falling more than once. So this remains our report at the top report adverse event. In the VA, our primary outcome was making sure people don't get injured as a result of a fall. Michelle, as I close, I always encourage everybody to approach everything they're doing with data collection and quality improvement with rigor. And I encourage people to go back to the Squire guidelines, because the Squire guidelines were designed to help you be able to publish your work. To publish quality improvement and program evaluation, you have to have rigor and you have to have data. You have to have questions, you have to have measurement tools, and you have to be able to fix your implementation. And I've published multi-scale, multi-site quality improvement projects, and I know you can too. So I want to thank you so much for inviting me to be able to present. I know it was a lot of information. With that, I'm going to go ahead and then pass the ball back over to you, Michelle, I hope, because I'm not seeing you here now on the let me just see where you are. Second the ball back to you.
Thank you so much, Pat. So I know we are close to the top of the hour, but I did want to give participants an opportunity to ask questions that they may have of Pat while we have her here, especially, the measurement-related questions. So feel free to chime in if you do have a question that you'd like to ask. Raise your hand.
Please remember, too, I'm always available to you after the call. I'm not always a phone call away, but I'm always an email away.
So much, Pat. We know, and we appreciate that. So I don't see any hands at this point. But I just want to thank everyone for joining us today, and I hope that this has been helpful information. I think this slide deck is going to be very valuable for people to go back to and look at. But unless there are no questions, I just want to thank everyone and remind you that our next webinar is on Thursday, October 20th. And thank you again, Pat, for comment?
Yeah, I had a question.
Go ahead, Terry. Is that Terry?
Yeah, correct.
Okay.
Terry Hostert from McDonough District Hospital in Macomb, Illinois. One thing that my experience in quality is the whole Plan, Do, Study, Act is all associated towards run line charts, time-ordered data, and that has very rules. You have control chart rules you can use to identify that a special cause has occurred. And this type of science is very different from clinical trials, which take time out of it. And so it seems to me in medicine, in hospitals, let's say, and where you're providing process and taking care of folks, there's this disjointedness from the people who are in charge of giving orders, the physicians that are very much used to and comfortable with these clinical trials that don't have time in it. And so I think they see this kind of study where it's time-ordered information as plain than clinical trials. And how to break that cultural difference,
Yeah, and thanks so much, Terry, for that question and the comment. I think it just depends on what it is you're implementing. It's just like the Postfall Huddle. Now, when we launched the Postfall Huddle, it wasn't a clinical trial. We didn't have a control for intervention group, but we modeled it after action reviews in the military, where you bring people as close to the event, together as quickly as possible to try and figure out what just happened. That's done in the aviation industry, So that's how we built it into a process, a time measure there that it should be done within 15 minutes. So PSA cycle, that's one of the things that you want to measure. That would be one of the process measures that you would have in place. Do people come together within 15 minutes? And a lot of times when I hear people talk about postfall huddles, they're convening their postfall huddle at the end of the shift, or 2 hours later. Well, that's not as it was designed. So that's why even in a quality improvement initiative, you can still have a process measure that's a time measure. It's just very different. It just depends on what you want to do. Just like floor mats, if you have someone who gets admitted to a hip fracture or has a hip fracture already, it's not okay to wait 48 hours to get a floor mat to the bedside. But I guess it still comes back to what you're trying to do, because if it doesn't work, if it's not timely, it's not going to be effective for us in being able to protect someone, if you will, in terms of the floor mat. So I hope that just kind of sets the stage. You have to decide for any intervention that you're implementing, if this is the kind of rigor you want to do, if you're going to really launch something, an intervention, we commitment to it, because it takes a lot of staff time to make something work, to get people up and running for it, as you'll hear from Kate, to be able to launch it. And you don't want to just roll things out without having some expected outcome. So that, I think, is where the PSA cycle doesn't have to be linear, but it has to help with looking at how do we go from a small-scale pilot testing to being able to do spread.
Thank you, Pat, for your response.
Oh, you're so welcome. Thank you.
Are there any other questions that anyone would like to ask?
I'd say still, Terry, where I think we got so much traction with the PDSA cycles from IHI, because IHI with the TCAP project, Transforming Care at the Bedside, really wanted to get action-oriented and for people not to wait till clinical trials got published, to get people involved in change, and to people be implementing change after they just got the policy that was going to be implemented hospital-wide or unit-wide. That we have a say, and people had to come together to see what works and what doesn't work, so that you have more probability for success. So they really get credited for giving us a lot of traction at the point of care about doing the PDSA cycles, so that you can be successful. But if something isn't value added, just like the Postfall Huddles, I mean, if the nursing staff at night would have told us a very different story, who knows if we would have continued them. But when you ask people, this is really worth it, to bring people together in the Postfall Huddle, when you hear something like, we didn't have to deal with it alone, that was the most important thing. Well, I mean, that just sets the whole stage for this is so important, we're going to go forward. So I think whenever you look at whatever we're going to do, if there's really a commitment to it, we want it to be successful, otherwise it just fades away. And we've all been doing it. That's why we all end up drifting universal fall for cons. It doesn't work in a score. It's like, well, how did this happen? So how can we make it different? How can we make it different? Michelle.
Yes, thank you so much, Pat, and thank you for sharing all of that valuable information, and thank you everyone for joining us today. So again, we will meet next time on October 20th, a Thursday at 1 p.m., and we hope you can all join. It's going to be another great presentation. So thank you, Pat, so much.
You're so welcome. Thank you. Everybody have a great afternoon. Bye-bye.